This week is one of our tumor boards, and we have some really fantastic and challenging cases brought to us by Dr. Smith from up in Rush. As usual, we'll do some introductions here, and we'll have the folks sort of go around the table here and just do an introduction. We'll finish with Dr. Smith and let her bring her slides up at the same time when she introduces. I'm Mike Tuttle. I'm one of the endocrinologists from Memorial Sloan Kettering Cancer Center. Dr. Pitoia.
Hello, everybody. My name is Fabian Pitoia. I'm from Argentina. I'm an endocrinologist from the University of Buenos Aires.
Thank you. Dr. Urken.
Yeah, hey, Mark Urken here, head and neck surgeon in New York at Mount Sinai.
Dr. Khorsandi.
Radiologist, Mount Sinai, New York.
Fantastic. Dr. Baloch.
Pathologist from University of Pennsylvania in Philadelphia.
Perfect. Dr. Ghesani.
Hi, good morning, everyone. Munir Ghesani, a radiologist and a nuclear medicine physician, a chief medical officer of United Theranostics, and a faculty appointment in radiology and neurosurgery at Mount Sinai.
Fantastic. Thanks, Munir. And last but not least, Dr. Agosto Salgado.
Hi, good morning. I'm Dr. and I am an oncologic endocrinologist at Moffitt Cancer Center.
Fantastic. All right. And Dr. Smith, you can introduce yourself.
I'm Pinar Smith with endocrinology at Rush. It's an honor to be here. I did my fellowship at Mount Sinai and did a rotation at Memorial Sloan Kettering. So thank you so much with the endocrinology department now at Rush. Thank you so much for having me.
Thanks, Pinar. And you've overcome those educational challenges to be fantastic. So let's start with your first case.
All right. Our first case is a 62-year-old gentleman who just had 5 weeks of a change in his voice. His past medical history was benign prostatic hyperplasia. When he went to the ENT, he had a laryngoscopy that did show right vocal cord in the paramedian position. This was his CT of the neck.
Dr. Khorsandi, never fair to show you individual pictures, but what are you seeing here?
So the right lobe of the thyroid gland is replaced by a calcified and hypodense mass. Most important is that the medial border is inseparable from the trachea. If anything, it's flattened the tracheal wall. I see some lateral compartment lymph nodes bilaterally, difficult to assess on this one image. And on the second image, besides the vocal cord paralysis, again, I see a calcified, pretty large, I would say 2.5 centimeter right lateral compartment, level 3, probably extending to level 4. Typical lymph node for papillary thyroid carcinoma.
Does the big calcifications mean anything, Azita? Does it think one way or the other, or just a description?
Well, the calcification and the avid enhancement are two clues that tells us this is metastatic lymph node from thyroid cancer, papillary thyroid. They're typical.
Gotcha. Okay, Pinar.
And this is as Dr. Khorsandi just said, right? And then we did an FNA of this mass and of the, right level 4 and lymph node, and it was malignant for papillary thyroid carcinoma. The patient underwent a total thyroidectomy. In bilateral lobes, there was multifocal thyroid cancer. Most of the foci were papillary thyroid carcinoma. In the right, we did have a area of follicular variant papillary thyroid carcinoma. And on the left, there was a NIFT-P. Going on to the lateral lymph node dissections, there were quite large lymph nodes measuring up to 4.4 centimeters with extranodal extension in the lymph nodes.
Yep. And Zubair, what are we looking at?
So it looks like a classic subtype of papillary carcinoma, beautiful nuclei, papillary formation. So this picture will be classified as a classic subtype. The same here. There is fibrosis, but which can be sometimes mistaken for the capsule. But I think that's where the dystrophic calcifications are. On my screen, the left-hand side, which looks much more darker blue and with a little crackling in it. So those are the dystrophic calcifications. So again, this is papillary carcinoma classic subtype, at least on this power. And that's interesting. It is a lymph node. And as you can see, the lymph node architecture is kind of distorted because the tumor is coming out of the lymph node. So that is extranodal extension. Now, this is very interesting because if you look at the top right of the tumor, in the thyroid that the pictures showed was more classic subtype of papillary carcinoma. But here you can see what we call as a collapsed papillae or the tram track appearance, that area. That looks like to me like a tall cell subtype of papillary thyroid carcinoma. It's so, I mean, at least on this power. And as you can see, there is definitely an extranodal extension. And at the bottom right, in that really tiny corner, that looks more like a classic subtype. And you can see how the papillary structure is a little bit fatter. So I think so there is a change either in the lymph node or there was some component of it in the main tumor.
Perfect. Pinar, go backwards for me to your first slide number 6, where we had the path report. Mark, I've got, yeah, right there. Mark, one more for me, Pinar. There you go. Mark, I've got a little disconnect here. I've got Azita's showing me this tumor that looks like it's invading in the trachea. It's really bad. And then I'm looking at this path report, and it's 1.5 centimeter, few small lymph nodes. Next slide for me. It's got some bigger lymph nodes, 3.5 centimeters, so it'll be kind of, I read through there, and the first time I read it, I missed the second bullet point that says tissue over the right trachea, metastatic papillary involving soft tissue. So how do you understand for me that CT scan, intraoperative findings, the path report, because I'm going to need that for staging, Mark. So can you sort of talk about that general concept?
Yeah. So I think really this starts prior to surgery, because we know up front that this gentleman's got a vocal cord paralysis. Overwhelming likelihood that recurrent laryngeal nerve's involved. We know there's going to be posterior extrathyroidal extension or alternatively involvement by one of the paratracheal lymph nodes that has invaded that nerve. So the innocence of the wording here belies what we already knew before we got to the operating room, that this is an invasive thyroid cancer that's behaving at least locally badly.
Yeah. So, Fabian, it's pretty easy for me because I see the surgeons every day. I bump into them every day. I mean, how in your context can you see the operative reports? Does it make any sense to you on a case like this? How do you do that in Buenos Aires?
Well, it's usual that we probably do not have we have a lot of patients that are referred to our hospital. So that becomes the problem where you cannot contact the surgeon. And sometimes you look at this pathology and you say, well, it's probably an intermediate or intermediate high risk patient of recurrence. But then, of course, you guess that this patient probably had an R1 or R2 resection that you cannot guess. And it's very difficult. You have to decide it over the follow-up. How is the response to treatment after having this very nice pathology report that is not related to what you thought, what you saw at the beginning of the disease?
Yeah. And Sarimar, you get to see a lot of these like Dr. Pitoia does when they get way downstream and they're recurrent and distant. What were the red flags? I saw you already smiling on halfway through the first slide. What were the red flags that you were sort of saying, boy, this is not going to be what it may appear. I need to look into this deeper. Sarimar?
First of all, history and physical exam. We're seeing that this presented as a locally aggressive thyroid cancer, regardless of what we're seeing, quote, on the tumor primary site within the thyroid. The fact that there was extensive lymphovascular invasion. We know that when there's bulky lymph nodes, more than 3 centimeters, by ATA 2025, this is a high risk thyroid cancer, more than 30%. I would say probably even more than 50% in my practice. These are patients that, usually it's super important to have, as it has been outlined, the communication with surgeons, trying to dig into that operative report. And I actually tend to have a very low threshold of actually restaging these patients and looking even below the neck to understand the full picture at the time of presentation before we start thinking about adjuvant radioactive iodine.
Absolutely. So the key to this is that initial risk stratification. We used to always think it was the path report, but now both HACC and ATA are really clear that it's everything that happens preoperatively, everything that happens intraoperatively, and up to the first 4 months postoperatively. So we have to think about that as an umbrella. Mark?
Yeah, just real quick thing here. For those of you who might be interested, we put together, Mike and I and a couple of the other co-authors on the panel today, and a checklist that is located actually within TIRO under statistical tools or actually analysis tools. And it's a checklist that the surgeon can go through and precisely identify what they found intraoperatively and then just print it out or send it directly to the pathologist so that they know exactly what we were seeing in the operating room. And it's a really neat and concise way to convey that information.
Very good. Okay, Pinar, take us up to your interval history and let's see what happened to this patient.
This patient did receive 149.8 millicuries of radioactive iodine. The post-treatment scan just showed some residual tissue in the thyroid bed, also in the kind of midline of the neck. They were saying likely a remnant of the thyroid duct, no other metastatic lesions.
Munir, in this case, we've been talking about this like gross invasion to begin with. Do you do more upfront with the radioactive iodine? Do a PET with it? Do CT? On this particular case, how would you do that first sort of pass through with radioactive iodine?
So I think the CT would be difficult with the contrast because we are preparing them for the iodine administration. So we actually, if anything, we have to deplete even their inherent iodine source. So we put them on low iodine diet. But we definitely, in a case like this, for sure, Zubair showed the tall cell component, invasive disease. FDG PET is very useful in this setting. Also, with regards to the fact that if they show up iodine avid and we have to go for a higher administered activity, we should be considering dosimetry in the case like this, so that the patient I see on the slide here that received 149 millicuries, but if the dosimetry was done and if the organ at risk could tolerate more, and if the remaining targets need a higher grade dose, then I think that would be very critical as well.
Yeah, because we're not thinking about adjuvant therapy here. We all think this is R1 resection, possibly even gross residual resection. So we're taking it up. Okay, Pinar, take me through the rest of her management, and then we'll get to your questions. Walk us through the case here.
Okay. So the patient did start developing some trouble swallowing in November 2024. As you can see, the biochemical response to therapy was excellent for a while, but then around that time did become indeterminate. I got a whole body scan that was negative. We did get a PET scan, which showed these images. And the PET scan did show a lung nodule as well as an area in the posterior right thyroidectomy bed, and the SUV was about 14.8, and the lung nodule SUV was about 9, consistent with metastasis. On the CT chest, it was better seen that the nodule was about 1.6 centimeters in the lung, as well as some other nodules. The biopsy was done of the lung nodule, and it did come back a poorly differentiated carcinoma with a solid growth pattern. The liquid biopsy with Tempus did show a KRAS mutation. No extra radioactive iodine was given. However, it was recommended, given that the pulmonary nodules were over 1 centimeter, and it was thought that the PTC had dedifferentiated, that lenvatinib 14 milligrams daily was started in January. However, the medication was held for about 2 months because the patient was trying to get a prostate biopsy done, which he did do. It came back benign. And now he's resumed on it as of about a month ago.
Okay, pause for a second. Go back one for me. Zubair, I totally was not seeing a KRAS mutation coming here. I was expecting BRAF or something plus tell me a little bit, what are you thinking here?
So if you really look at all the papillary cancers, all comers, regardless of the subtype, the RAS mutations are only seen in about 11% of those in the largest meta-analysis. Naturally, regardless of the anecdotal cases. But it's very interesting that when you have a poorly differentiated transformation or anaplastic transformations, you do see an increase in number of RAS mutation. So we don't know what the tumor had because it was not done on the initial tumor. So, and in those cases, you will see more of the RAS mutation, which is also shown by the memorial data. And they are in that poorly differentiated group. And the KRAS is, as we know, is the least of all the RAS, but it is associated the increased number of carcinomas because the most common is NRAS, which also can be seen in benign. So for me, this is really follows what has been reported in the literature.
Yeah, I think we think that the KRAS was probably there from the beginning, but possibly a smaller clone that just grew out, or do you think it's a second?
That's always possible, but you remember the KRAS, the BRAF, and the BRAF, they occur independent of each other. So you do not have a tumor which has a BRAF and a RAS, right? So I think this may be one of those tumors, because we're showing, as I always say, there are two main buckets, right? The BRAF-like and the RAS-like. But then there is the middle bucket, which is not following, nothing is black and white. So in that, I think this tumor can be in that group. So
yeah. Okay,
Mike,
one more there, Pinar.
Sorry, Mike, can I say something? Because
please.
There is something interesting here, which is the excellent response to treatment in a patient with a locally advanced disease that probably now we know this is a poorly differentiated thyroid cancer, but we took for granted because we have an intermediate high risk, probably with not taking into account what happened at the beginning with the locally invasive disease. Then we see an excellent response, even indeterminate, but almost excellent response. And then this locally advanced disease. This is not very frequent. So we can rely on these thyroglobulin and TG antibodies when we have the pathological report showing the intermediate risk and then seeing an excellent response to treatment. We probably have done exactly the same, saying, well, this patient is doing well. Until she or he had the swallowing problem in 2024. But it's normal that if you have an excellent response, that this is not very frequent for this kind of high-risk patients.
Yeah, agree. And that's the real key to getting this guy classified as really high risk to begin with, right? So we were getting fooled on that pathology report, but Sarimar had already had him at 50% chance of risk of recurrence, and it's pre-test probability. So if you look at the people that are really high risk that have an excellent response, this kind of response happens 5 or 6% of the time, as opposed to like never if it's in that intermediate group. So, but agree totally. I mean, this must either have a tumor that's not making thyroglobulin very well, or they had some unmeasured antibodies that we didn't know. But yeah, absolutely right. I mean, it looked like, I was still worried about it, but it looked like maybe this was going to be one of the high risks that was going to do well. And maybe if you had the op report that was just barely involving the nerve. But yeah, that's a good thing that these guys that are high risk to begin with, you're not de-escalating their follow-up at 5 or 10 years. And sometimes you even need to throw an extra CT scan down the road at 2 or 3 years and not just rely on the ultrasound. So good point. All right, Pinar, where do we go from here?
I just wanted to show that in that 2 months of stopping lenvatinib, there was some growth of the right tracheoesophageal groove mass as well as the lung nodule. So the lenvatinib was restarted at the same dose and then with a plan to increase it. And these are my questions for the group.
So some challenging questions we haven't seen before that really get around. We'll do Dr. Pitoia and Samar and Munir here. So do Munir, do the third one for me. So when we're given radioactive iodine, that my opinion often is not very helpful. Are we selecting out RAI refractory clones, or are we doing anything bad, or is this going to happen because we're going to kill the RAI avid stuff? How do you think about that question, Munir?
Yeah, so the general knowledge is at the time of staging, there is not that much heterogeneity in thyroid cancer. It evolves over time as they become dedifferentiated. So de novo, we find that there is more homogeneity. And I again make that case that if we could give these patients knowing high risk, almost all the time when we see them, we go through a dosimetry protocol. So we know we have one best chance up front to eradicate, if possible, all macroscopic and even microscopic disease. In terms of this patient's risk, I wonder if we had the opportunity to fully look at the genetic profile and if the KRAS was there, but if there was also a third promoter mutation with it, because the data have shown that if the two together are more likely to be iodine refractory. And if we had picked that out, that would have allowed us to consider a different approach, including potentially other treatments in combination with the radioactive iodine. So I think that would be the overall assessment for this case.
Very good. Dr. Pitoia, what about this sort of logic? Just wait till they get their distal metastasis and treat them then, as opposed to, it's the discussion between adjuvant therapy, treating a risk, and waiting until you have disease. Preference? What are you thinking there, Fabian?
Well, I think that this theory of selecting clones, I don't agree. I don't have the answer of that. I think that for when you have an aggressive thyroid cancer, it won't respond, and it will be all right and refractory, and you continue having the disease, and then you realize you have the disease. I don't know if I'm answering the question you asked me.
Yeah. Yeah, Sarimar, what about, I like the second bullet there. If you have high-risk patients and you don't give them radioactive iodine, is there a chance they never metastasize? Because patients ask us that. So what do you say?
No, not really.
No, what do you mean not really? Okay, so I'm going to lose my mind here.
So in reality, to me, the chance of these tumor metastasizing is coming from the intrinsic biology, not whether we're giving, radioactive iodine. In fact, the evidence as of right now, this is actually the population where you want to potentially give that one chance to radioactive iodine, as long as obviously you don't have rapidly progressive disease or a different indication for systemic therapy up front. But these tumors, especially as they start differentiating or being more higher risk, you can see, for example, in the poorly differentiated thyroid cancers and higher grade tumors, that even a diagnosis, they can already have metastatic disease, sometimes up to 20 or even 50% of the times. So it's not really intrinsically related to to administering radioactive iodine, is that they already have that potential of metastasizing. I do think that probably there's certainly more to the story than what the liquid biopsy is telling us, especially with poorly differentiated thyroid cancers, as it was beautifully outlined. We tend to see late events like TP53 or TERT or even PIK3CA. And these additional mutations sometimes result in poor TG producing tumors. So these are usually patients that, if I already see a higher risk to begin with, and again, may not necessarily align with all guidelines, but I do tend to periodically incorporate, even if they have quote unquote what seems to be a biochemical good response, I would still periodically look beyond the neck to make sure we're not missing anything on the story.
That's very reasonable. The trouble we have with risk stratification is I get to press back on Sarimar because she gives me hard times on tumor boards. What she just outlined was 100% risk of distal metastasis. Because the question is, might these never metastasize? And the answer is yes. The risk of metastasis is probably, 30, 40, 50%? So they don't all metastasize, but the trouble is we don't know which ones they are. And we don't see the ones that don't metastasize, right? So I don't know anybody that would not have given this patient radioactive iodine with this histology, with this probable microscopic residual disease, gross residual disease. So I think everybody would have given this patient 150, and I would have actually had hopes this might have worked based on that histology. So I think that's where we are, and we talked about progress.
I agree, and I'm sorry if it was misinterpreted, but yes, this is very clear the population where you really want to potentially give that chance of radioactive iodine, where there's really not any controversy. But if a patient comes to me and tell me, if we don't do radioactive iodine, can I still have a slight chance of having metastasis over time? I would say yes, there's still that chance of metastasis over time, and we would still have to follow these patients very closely, regardless of whether we do radioactive iodine or not. But I would still advocate for giving them that opportunity, especially with that risk more than 30%.
Agree 100%. Any last comments? Munir, go ahead.
Yeah, well, quick comment. I think for a high-risk patient like this, over the last 2-3 decades, we have moved away from post-radioiodine therapy routine imaging. But this would be one example where I would consider a follow-up at 1 year after low iodine diet and performing the iodine scan as well as FDG to make sure that we can pick up any residual disease. As was discussed, this was low thyroglobulin producing disease. That gives us the opportunity to pick that up earlier before it's too late.
Totally, Munir. It just emphasizes this. It's so critical to get this person staged right on day one, right? That we're all thinking them as a high-risk patient. If they have an excellent response, we don't celebrate. We go, that's probably okay, but let's really make sure beyond more than just the ultrasound and the thyroid this is an excellent response, right? Great case. Okay. All right, Dr. Smith, give us another one. What do you got next?
All right, our second case is going to be a 75-year-old female with osteoporosis who presented with neck swelling, no trouble swallowing or no change in her voice. She did have a right-sided palpable mass that was non-tender on the right side. This is her laryngoscopy exam.
Mark, do you want me to explain this, or do you want to do this one?
Go right ahead.
Okay, so that's the colon, and go ahead, Mark. Tell me what I'm looking at.
Yeah, so that right vocal cord is moving a little bit, but not as much as the left side here. And so we would be very concerned going in that right recurrent laryngeal nerve is affected by what's going on in the thyroid bed.
And the right vocal cord, Mark, this is backwards, right? So it's the one on the left-hand side, the way I'm looking at it?
That's correct.
Got it. Okay. Nice video. Thanks, Pinar.
This is her CT of the neck.
Azita?
So again, we have this heterogeneous, multilobular, and large mass replacing the right lobe of the thyroid. So two things. One is that the fat interface between the mass and the esophagus is gone. Now, I keep saying it over and over. I don't know what that means. Does that mean the esophagus is invaded? I don't know. Or is it just pushing the esophagus? Or is it just the muscularis that it's involved? I can't tell. No one can tell. But so that's one of the risks. If you look at this one, that I think, and I use the word I think the trachea is intact, the tracheal wall. I can see that interface. However, the lateral interface with the carotid sheath, again, the fat is not there. In this case, the lateral wall is the most concerning to me if there is extrathyroidal extension. And again, I see lateral compartment lymph nodes, ipsilateral.
Yeah. Mike, let me just challenge Azita there. Gosh, it is really hard to tell, but if you look at the plane of the tracheal cartilage on the left side compared to the right, that right side looks really, really worrisome to me. Obviously, knowing that there's invasive thyroid cancer may cloud my impression here, but I'd be really worried based on that image here.
This one, on imaging, I'm not as concerned as the last case because the last case, it went to the edge. This one, I don't see it going to the edge as much. I can sort of see a separation. I'm not sure. But again, it's something we've argued over and over again. The esophagus is worse. The trachea, I can say, I see to the edge. But other than that, I can't specify. The carotid sheath, I can be more clear.
Gotcha. Let's show some more pictures, Pinar. All right, that's the same images that we talked about, right, Azita?
Yes.
Okay, let's show some. There you go. Here's just some more, Azita.
So again, we talked about the mass on the upper left. We see all those images show the same thing. On the coronal images, it's more of the same thing we talked about, but honestly, on the coronal images, I know Dr. Urken may not like the bottom image on the right hand. I can sort of see it doesn't go into the tracheal lumen, and I can see some of the trachea sort of that's intact. What I don't like is on the bottom image, it's apposing the great vessel. I can't say if it's a vein or an artery in that one image. I think it's one of the veins. It may be the innominate vein. So that's one concern. The carotid sheath laterally is my second concern. I think those are the big things that I can see so far.
I gotcha. Okay.
This is the report.
Yep. Next slide.
We did do a biopsy. The right-sided mass was replacing the whole lobe. The patient did have a total thyroidectomy, bilateral and lateral lymph node dissection.
Okay, stop there for me. Go back to the one more, back one more. All right, cool. Mark, this discussion in your office, I'm going to give you like 5 minutes here because it's going to take a little bit of discussion about what you consent them for, what type of surgery you consent them for. And then Sarimar, there was a question about maybe using neoadjuvant to kind of help here if it may help. So Mark, tell us, if I'm an endocrinologist kind of sitting and listening and you have this discussion with the patient, what are you going to tell them about the surgery? What information are you trying to provide to them? And that I'm sure it'll be a series of conversations, but help me understand how you're thinking about this, Mark.
Yeah, so there are a number of things that need to be conveyed to the patient, and hopefully a friend or family member who's there to be a part of that discussion. The most important thing is that my mindset going in is really guided by what I'm seeing on that flexible fiber optic exam. And based on the imaging here. So the key points really relate to, is the trachea involved? Is the esophagus involved? How am I going to manage that ipsilateral nerve? And what is almost the most important thing is the postoperative status of the contralateral nerve, which is going to guide how this patient's airway would need to be managed. So the major issue here has to do with the surgeon's mindset going into this, that this is probably in this age group, as opposed to perhaps a younger age group, not a disease where you can have a backup plan. Now, if I leave some, it's going to be RAI avid. I go into these cases with the mindset that I really need to do an R0 resection because I want to prevent this patient from having to undergo external beam radiation. And so have lots of discussion related to that, the potential need for tracheal resection, the possible need for esophageal transmural resection, knowing full well that in these cases, often the muscularis can be resected and preserve the mucosa and thereby avoid the need to reconstruct the full thickness defect of the trachea. But we talk about what we can do to potentially ameliorate the postoperative vocal cord paralysis with nerve graft, nerve anastomosis, Azita, Khorsandi anastomosis, and what the implications of doing a tracheal resection are if we find that that's indeed necessary.
Yeah. So Sarimar, in other cancers, we're very familiar with neoadjuvant, where we give some medicine to shrink things down to make it easier for the surgeon and sometimes get pathologic response, right? Where do you kind of read that literature now in thyroid cancer? Not the medullary, but these non-medullary ones.
There's still a conversation, obviously, to individualize in every case, and it highlights why these more complex cases of presentation actually benefits of having teams that are working together. Because at this point, we don't have any molecular data from this tumor, but there's basically two different avenues that it could be considered systemic therapy-wise. So in a nutshell, systemic therapy usually has been considered in thyroid cancer when there's a disease in a threatening location, when there's a symptomatic disease that you cannot treat basically in a different manner, or if you have a RAI, a progressive disease, or certainly in scenarios where you have widely metastatic disease that's rapidly progressing. Over time, as some of these agents can have significant decrease in tumor burden, the option of using them pre-surgically has emerged. If we were to think of a more general multikinase inhibitor, we would be thinking for which was the medication used also in the prior case, which is an anti-angiogenic, meaning it also works on the little blood vessels that support these tumors due to the vascular epithelial growth factor effect. And these medications, even though they're pills our patients take at home, they're not completely benign, meaning they can have significant hypertension, there's certain cardiac risk, there's certain abnormalities that can happen with electrolytes, blood counts, and more importantly, when disease is locally invasive to the trachea or the esophagus, as the tumor is regressing, there are some risk of fistulas. So really, it's a conversation in this case to have certainly with the surgeon. What's really the goal? Are you looking for trying to make margins a little bit better? Are you really looking to have a significant decrease in the tumor size to be able to make this resected? resectable. If we were not, sometimes we don't necessarily see a rapid response within weeks. Are we going to lose the surgical window if we don't take this patient to surgery quickly? So those are all the different nuances that we take into account. If we were to find something in an NGS on this biopsy, usually the most common alteration we see in papillaries are BRAF positive alterations. And these alterations, even though the drugs that we use, like the dabrafenib, trametinib, in, for example, the full the other side of the spectrum, which would be anaplastic thyroid cancer, we see very rapid shrinkage. In reality, when we think about papillary thyroid cancers, the responses might be way more modest and may not necessarily change rapidly potential surgical approach. In the rare percentages where we can find fusions, maybe less than 10% of differentiated thyroid cancers, and maybe Zubair can weigh in on that, the fusion-driven therapies actually do have profound responses. So if my surgeon tells me that he would think this case would benefit of neoadjuvant approach, I would advocate to look at the NGS testing to really make an informed decision of what are my options, and I would stage those patients very closely. And it's a case that it should be follow along both with the person managing the systemic therapy and the surgeon to really determine what's the window. And of course, never losing the perspective of what is my whole patient looking like, what are their comorbidities, what things can get worse medically if we go the systemic therapy route.
So, Dr. Pitoia, take me back to the 30,000-foot view. These folks often come in through endocrinologists. They're seeing you first. What are you thinking about this case? You've seen the report. We're assuming there's gross extrathyroid extension. Are you thinking about surgery, radioactive iodine, external beam, systemic therapy? That initial trying to give the patient an idea about what might happen. So, talk through that for me, Fabian.
I agree with Sarimar that for us, the neoadjuvant setting discussion is something we would plan by the first thing in this patient, considering that probably our surgeons will say that the surgery will have a lot of adverse events in this case. And if we can assume that neoadjuvant therapy can regress, and this is completely different in Latin America because it's very difficult for us to have a panel, an NGS panel at the beginning. So probably we would choose lenvatinib as at the initial treatment for this patient. And we have very good, nice experience in our hospital with lenvatinib. But it's real that what we see in the clinical trials is not what we see in the real life. And this is very, very important. What we see in the clinical trials or retrospective series is that almost 60% of these patients will end with an R0, R1 resection. But in our real life, this is only 25% of patients. And probably it has to do with we have a more advanced, this is my impression, in Latin America, we have more locally advanced disease that it is usually probably with socio-cultural or economic issues. And this is a completely different situation. I think for this patient, we would talk with the surgeon and with the patient regarding the use of neoadjuvant therapy at the beginning. And of course, I'm thinking that after that, if the patient does not have any other lesions, metastatic lesions, we can withdraw lenvatinib and then rethink about giving radioiodine after surgery.
Fantastic. Mark?
Yeah, I think there's probably very much surgeon to surgeon in terms of how they look at these imaging studies and kind of what their mindset is. We are using an accelerated amount of neoadjuvant therapy in squamous cell cancer of the head and neck, and induction immunotherapy plus minus chemotherapy. We all get extremely excited when we see a significant number of patients having no evidence of disease when we take them to the OR. But there is an odd insignificant percentage of patients who do have microscattered microscopic foci of disease within the original tumor volume. And so the temptation there is to do what we call response-adapted surgery, where we are looking at a shrinking volume and say, all right, we can take out less. But we don't know what we don't know, which is what is the entirety of that volume to know, are we really changing the picture on that particular patient in terms of local disease. So that's just a note of caution there.
Yeah, I think the other note of caution is that there's been lots of studies that look at why we all decide to do something like neoadjuvant therapy, and then 10 years later we figure out it's not the right thing to do. And one of the common things is there's a great mechanism of action, and intellectually it should work. You'll see that over and over and over again throughout not just thyroid cancer, but everything. So it gives me caution in areas like this because we're all doing this because it really should work. Sarimar gave us the exact logic. There's a mechanism of action. It really should be better if things are shrinking. But I think in areas like this, we have to be careful and make sure that there's enough data for us to be doing this. Even as like Mark said, if you get this great shrinkage, what needs to come out? Are you leaving microscopic, particularly in squames, right? They can grow back in no time. So lots of information here. Sarimar, like you were going to say.
No, I fully agree with you. I think that it is key to individualize. This is, again, going back that thyroid cancer, it's not really a cookbook approach. This is something that you really have to think about the patient that you have in front of you. What are their comorbidities? What are their status? And then most importantly, the conversation with the surgeon. Really, what are we trying to accomplish with neoadjuvant? And what are going to be our plans if we get that response, or as Fabian beautifully outlined, if it does fall in the corner where we're not seeing the response, when are we going to say, do we take this patient to surgery? Do we keep them on systemic therapy long-term? Or do we resort to radiation therapy?
Yeah, and our experience is the same. As we talk about it every Thursday morning, we're very selective about when we do it. And it's when we think even a little bit of a shrinkage would give us a great advantage. We'd be unlikely to do it on one like this. We doubt we get enough advantage here. Okay, so let's catch back up where you are and show me a picture of the OR. I have no idea what I'm looking at. Mark, what am I looking at?
Yeah, so this is part the resection here. It looks like we are looking along the right side, and looks to be adherent to the trachea. And that's how I would probably put this together. The surgeon is showing that he's not able to clearly get a surgical plane. That's my guess in terms of this without a narrative.
Okay, all right, and show us the next slide there because we got the things. All right, Mark, where are we? I mean, you can't read that video there, but take me through kind of the decision making. I mean, I assume this was on the side the nerve was out already, right?
Yeah.
This is the right hand side. So talk me through that if the nerve is out already, and then tell me what you're going to be careful on the other side there, Mark.
Yeah. So this is clearly this is a case where we go in expecting that the recurrent laryngeal nerve is going to be invaded, and the chance of being able to save that in a non-functioning nerve already are extremely small. And so I will look to preserve that distal end and proximal end if possible. Often there's invasion at the level of the joint, which makes it very, very difficult. I will end up resecting that, which puts a great deal of pressure on dissection on the contralateral side. But again, this is a case where intraoperative neuromonitoring is exceedingly helpful and extremely useful for making sure you've preserved the integrity of that opposite nerve. Having said that, I mentioned about the esophagus. We always put in a bougie, which is extremely helpful here to be able to help to establish the plane between the muscle and the submuscular plane. And what I'm looking for primarily when I'm taking this off the trachea is lessons learned from the Shin classification of tracheal invasion, where he showed that invasion occurs in the intercartilaginous interspaces there. That's the route of entry to get into the tracheal lumen. And if you are critical in looking at that, you will tell it's not the cartilage, it's really that interspace that's going to tell you that you've got disease that you're leaving behind. And in that situation, I will not hesitate to do a tracheal resection here with the intent to use Frozens to get myself a clear margin.
Yeah, and Mark, we hear you guys talk about tracheal resection all the time. We're not going to get to the third case because there's good stuff here. When you say tracheal resection, what do you mean for the endocrinologist, so that I have some idea what you've done when I see that patient back?
Yeah, so we are taking the trachea as that deep third dimensional margin here in an effort to clear that margin. For all the reasons, we don't think we've got a backup plan of using radioiodine to sterilize this area. So I see this really as a surgical problem, and I really will do everything I can to avoid the need for external beam radiation afterwards. We're going to be talking about radiation in a couple of weeks here with some case presentations, but I really, in the presence of a nerve paralysis already, or vocal cord paralysis, I want to do everything I can to avoid external beam.
And you can take out part of the trachea, you can take out a window. Basically, it's like Legos. You plug and play, put it back together, and the patient really can't tell any difference if it's done correctly, right? They don't breathe any differently. Everything works well. Is that the way this works?
Yeah, basically. I mean, there are nuances. I'm not going to send you to the operating room based on that, but at the end of the day, the risk of developing a stenosis is small. You've just got to have that contralateral nerve well visualized, protected, so that you do not do something to that opposite side there. But at the end of the day, patients can function extremely well. It's not without risk. Postoperative tracheal breakdown, it can be life-threatening, devastating. But at the end of the day, this can be done in experienced hands very effectively.
Yeah, Sarimar's comment's exactly right. In cases like this, it's that surgical expertise. Doctor shows a slide of a lion in a cage. When the bottom of it says, "Don't get into the cage unless you know how to get out." And so this is one of those great series. All right, let's look at the path report, and then let's show Zubair the path so we can see what's going on.
Path report, the 3.2 centimeter classic type papillary thyroid carcinoma. It did have extension into surrounding tissue and posterior margin. There was microscopic disease on the esophageal margin, and in the tracheoesophageal groove, there was PTC involvement, only one lymph node without extranodal extension.
Hey, Zubair, yeah, go ahead, look at the slides here. All right, what do you see here, Zubair? Oh, you're muted there. Unmute there, Zubair. There you go.
That looks like a classic subtype of PTC. It's pretty dense. I mean, I don't see any necrosis at this point or mitosis, whatever is shown, but this looks like your classic, subtype of PTC so far.
Go back one slide for me, Sarimar. Zubair, take me through this margin issue. In both the World Health Organization and now in the ATA, to be able to risk stratify, I got to separate anterior from posterior. Take 3 or 4 minutes and sort of help me understand how I do that and what that means. Zubair, you were part of the driver on that, I think.
Yes. So, I mean, when you're looking at a surgical pathology specimen that is given to us, I think the posterior margin is the most important because there is not much tissue there. And when you look at the data, which is different authors, and it's been going on for a long period of time, that's where the most recurrences are happening, structural recurrences in the posterior portion. So I think it's really important to ink that area. And it's not just because you want to ink it so you have a specimen and you say, okay, whether the tumor is going there or not. You also have to realize there are different structures in that area, including some aberrant pieces of skeletal muscle, which can be embedded in the thyroid, large blood vessels, nerves, and other type of fascias. So I think it's very important for that portion to realize, because when you have a tumor which is going up now, definitely you have to decide that does that extension matches with the operative report. So I think it's very important, and the new data from Korea and other places have shown that there is at least 2 to 5-fold increase in the structural recurrence if the posterior margin is positive. Naturally, it does not match the multivariate analysis, and I think that was one of the reasons we did. Anterior margin, I think, is important also in the fact because sometimes when there are very large tumors, there's not much tissue around it, and they're basically sitting, jutting out of the thyroid like nodules, and when you ink it, you have to realize sometimes to say, okay, it is close to the ink, or it is, and I think that has not shown to be increased the recurrence rate. So when you're inking the posterior margin, inking the anterior margin, I think for me, it really aligns me with this slide to show where the tumor is in relationship to that ink and what it is invading, and then I can relay that in the report. I personally believe any type of invasion, extrathyroidally, macroscopic, or if it matches macroscopic, which we know matters, I really respect that. So for me, it gives me an idea. And remember, this is a specimen margin we are talking about, right? There may be more tissue that's left in the patient.
I got you. Mark, the good Dr. Shah taught me 20 years ago that he didn't really worry about anterior extrathyroid extension because he'd always get me an R0 resection. It would come with the strap muscles or whatnot. And the posterior was the problem because you really couldn't necessarily get an R0 resection. Is it as simple as that when you think about it, Mark?
So to a large extent, yes. I mean, with the exception of professional voice users who are very dependent on the strap muscles for the finest qualities of their voice, removing the strap muscles for the vast majority of us really doesn't cause significant dysfunction. But for all the reasons we mentioned, when we're looking posteriorly at the tracheal margin, the esophageal margin, the recurrent laryngeal nerve, that's really where the rubber hits the road in terms of what the potential morbidity is for that patient. And so, yeah, I mean, I think that really tells you what the surgeon's perspective is.
Dr. Pitoia, how do you figure out in your setting anterior margins, posterior margins? I mean, I end up guessing from the CT pre-op. How do you sort that out, Fabian?
Well, in fact, when we had some data from our studies showing that there was no difference, but the number of patients was really low. So, of course, we imagined that the posterior margin was something that was given as an R1 resection, and that R1 resection needs some actions after the initial treatment, probably radioiodine. If you have a radioiodine refractory tumor, to use external beam radiotherapy to prevent structural recurrence in the neck. Of course, we can suspect that at the beginning with the extension that it will be completely a section, and we assume that the patient will have an R1 resection. Even an R2 resection might be suspected at the beginning in the images. And it usually depends, as also as Sarimar and Mark said before, it depends on the surgeons. So if we have a surgeon that is not very well specialized in neck and thyroid surgery, we may have not an R1 but an R2 resection in this case, for example.
Yeah, which is challenging. Dr. Ghesani, finish this one up for me here. So let's assume we had the report said all evidence of gross disease was removed. They scraped stuff off the trachea, they scraped some, maybe took the esophageal musculature, but we don't have any gross residual disease left. But clearly positive margins, that sort of stuff. Radioactive iodine, PET scans, external beam, sequence. Talk me through that in a couple minutes here, Munir. What are you thinking?
So I think the external beam is probably not a good choice here because we don't have any evidence of gross residual disease. But in terms of the patient's overall prognostication, the risk of, this would be a high risk of recurrence. And, radioactive iodine treatment, again, I think this would be another case where I would perform dosimetry. And I would also add the FDG PET-CT to round out the appropriate pre-therapy workup. And this would be another case that while the trend is moving away, there are selected patients in whom a 1-year follow-up with stimulated thyroglobulin and iodine and FDG scan. And if everything looks negative, this patient's prognosis is much better after administration of radioactive iodine.
Yeah. So Sarimar, assume with me he got 150 millicuries, PET, nothing RAI-AVID lit up. He got a PET scan, nothing lit up. His TG is 1 or something like that, in that ballpark. What's your follow-up look like in the first kind of year in terms of, typically these guys do an ultrasound in 6 months and do a thyroglobulin, but in a guy like this, what's your follow-up really look like, Sarimar?
Yeah, so probably, and again, a little bit of art of medicine. People might do it a little bit different. I actually follow these patients a little bit sooner, maybe 3 to 4 months, and also have cross-sectional imaging. And I, tell the patient it's not going to be like this forever. Eventually, hope we can de-escalate to every 6 months. But this is a case where I would periodically also add cross-sectional imaging to make sure that there's nothing to the story that thyroglobulin or ultrasound neck is not telling me, especially with the type of presentation that the patient had.
That's fantastic. All right, Dr. Smith, let me say thanks for bringing us 2 really important back-to-back cases that talked about the importance of staging. And we love dynamic risk stratification, but you got to know where you started to begin with. We will continue this conversation in a tumor board, I think sometime next month, where we're going to take a deep dive with some of Mark's cases into the role of external beam radiation for both the adjuvant setting and the gross residual disease setting. So thanks to everybody for bringing these together. I think we've got some ending slides here for me so I can remember what to announce. TIRO, as Mark mentioned, and they put in the chat there some links to that. Voices of Wisdom, if you haven't tuned into those, listen to those. Those are terrific discussions and talks, sort of fireside chats. And then I think we got the next tumor board, Latin American Tumor Board. We've partnered with World Congress of Thyroid Cancer. I haven't looked, but I assume Dr. Pitoia is probably going to be part of this. He always is down there. So some great cases done from Latin America, which is awesome. And then we usually have what's coming up next. So that'll be coming up. So special thanks to all the panelists. Really challenging cases. Pinar, thanks for the videos and the CT scans. Really helps. I'm a visual person, so that really helps me get that together. So thanks again to all the panelists, and we'll finish from there. Have a great week, guys.